Hi everyone, hope you're all doing well. Thank you so much, organizers of ISNAC 2022, Dr. Nil and the team for giving me this opportunity. Um, I'll be speaking on IONM for pediatric neurosurgeries. Okay, so I bring you greetings from Cleveland Clinic, Abu Dhabi, where I'm currently working. Uh, to introduce, neurophysiology in children is different from adults. Children have immature nervous system, their synaptogenesis is not complete. So the IONM signals and the IONM waveforms are different in children. And there are various factors like age of the child, location of the lesion, type of the lesion, preoperative neurological functional status. All these determine the kind of IONM modalities we are going to use and how to interpret these IONM signals. There are also various challenges with anesthesia maintenance in young children and neonates and infants who come for procedures with IONM. So, for the outline of the talk, I'll first start with anatomy and physiological differences, and then I'll move on to types of surgeries, the common surgeries where IONM is used, and what modalities are used for each surgery, and then anesthetic considerations for each of these surgeries and techniques in these pediatric population. So children are not small adults. So they are not the same as small adults. So you cannot just generalize that because they have a different neurophysiology. Like I said, the nervous system is immature, the myelination is not complete, synaptogenesis is not complete. So they're completely different from adults. And the response also differs from child to child. So as the age of the child increases, the IONM signals also change. That is because of the maturity of the nervous system. So young children have thin calvarium and uh, infants have open fontanelle. So this anterior fontanelle closes by 13 to 24 months of age. So before this, we are many times encountered with meningomyeloses and spinal dysgraphism, these kind of cases where we have to do IONM. And here we cannot place the normal corkscrew electrodes because this is invasive and we are very often afraid that this can pierce the dura also. So we go for a less invasive stimulation technique on the scalp. We use EEG cup electrodes and sometimes simple needle electrodes also. So something to remember is the anterior fontanelle closes by 13 to 24 months of age. So before this, you have to be really careful. The posterior fontanelle closes by about 6 to 8 weeks after birth. So these are various types of stimulation parameters on the scalp that we use. Corkscrew, if the fontanelles are closed, you can use it. Needle electrodes, you can also use cup electrodes with plasters to keep them for stimulation. So the myelination is not complete, and this completion of myelination happens about 36 to 40 months of age. So until then, the neural pathways are not very well myelinated. So this is something which we need to remember. Because of this, even though there is the calvarium is thin, we expect, you can expect that at lower currents you might get good responses, but it is the opposite actually. You need to have higher currents, and the threshold for stimulating and getting responses is very high in this pediatric population. Something to note is also that the myelination of sensory fibers is before that of the motor fibers. So the sensory system is well myelinated before the motor fibers. Also, one more thing to remember in spinal cord surgeries or spinal dysgraphisms is that the dural sac ends at a much lower level at S3, and the spinal cord ends at L3 level at birth. And it takes about 2 years of age until the spinal cord comes to the normal adult level, that is up to the lower border of L1 that we call as the adult level. So any lesion around this area also we need to keep in mind that the spinal cord may be lying at a lower level. The various common surgeries where IONM is used in pediatric population are for the brain. You can use it for supratentorial tumors involving eloquent areas. You can also do them awake. So some children with motor lesions or speech lesions, we can do them awake, but not the very young ones, the ones who can cooperate and who can stay awake during the procedure. Deep-seated tumors like near the internal capsule or thalamus, infratentorial lesions like lesions around the brainstem, fourth ventricle, skull-based tumors, In the spine, deformity surgeries, spinal dysgraphisms, CV junction abnormalities. We see pediatric AADs and these kind of CV junction abnormalities, Arnold Chiari malformation, these kind of C1, C2 or CV junction abnormalities, and also spinal cord tumors. So coming to various modalities, about each modality, motor evoked potentials, we need higher thresholds. Like I said, there is a higher threshold for stimulation, so you need higher currents in pediatric population. You need to sometimes use multiple trains, higher pulses, and this is because of the incomplete myelination and synaptogenesis of the motor tracts. Less than 2 years of age, even the MEPs that are recorded are not very reliable. So it's a difficult process to get MEPs in young pediatric population. SSEPs in children, the latency and amplitude are highly sensitive to anesthetic agents, and this is again because of the immature nervous system. So SSEPs may also be very difficult to achieve in young children. So coming to EMG, that is the free running or the triggered EMG. This the EMGs can detect damage or irritation to the nerves, like the free running EMG or the triggered EMG by a stimulator, like a bipolar or a monopolar stimulator. This fortunately is not very affected by the myelination and the non-myelination in very young adults, very young children. So we can use this very effectively in pediatrics. So this is the most popular technique in pediatric neuro IONM. So for the spinal nerves, we can use in surgeries like tethered cord, meningomyelocele. For cranial nerve surgeries, you can use triggered EMG and raw EMG of the cranial nerves for brainstem lesions, fourth ventricular tumors, and various other procedures. So EMGs are easier to perform in pediatric population. The various other higher modalities or the advanced modalities like D-wave for intramedullary spine tumors, though they have been tried, the literature is sparse. Brainstem auditory evoked responses can be used in medulloblastoma, fourth ventricular lesions, ependymomas, and brainstem gliomas. VEPs, unfortunately in India we have the goggles which are very bulky and which do not stay in pediatric population, so it's very difficult. I tried them for a couple of cases, but the goggles are too bulky and we still don't have the scleral caps in India to place on the on the eye directly for stimulation. So the bulk is the thing, and also VEP is difficult in pediatric population. And like I said, adult awake procedures can be done in little older children, and we can use awake mapping and monitoring techniques. But for motor lesions, even though if we cannot do them awake, we can still do. There is enough monitoring techniques available now to monitor the motor pathways, even if we don't keep them awake. So speech is probably the real indication now to go for awake in these patients who may not be cooperative. So today's era is of multimodality IONM, and we combine a lot of modalities together to do IONM in these pediatric population, in adults as well and in the pediatric population. So it's not only one modality, it's multiple modalities many times. So to give an example, this is a spinal dysgraphism case. You can see that there is a split cord here. It's called diastomatomyelia. Here the surgeon's aim is to identify the fibrous tissue between the cord and to dissect it. So he has to identify whether this is a nervous tissue or non-nervous tissue. So with a simple stimulator, a bipolar or a monopolar stimulator, bipolar which is preferred in this kind of specific stimulation, you can differentiate the nervous and the non-nervous tissue. So you can place also anal sphincter monitoring. You can place needle electrodes around the anal sphincter, and the stimulator here you can see is when the stimulation is on the phylum, that is a non-nervous tissue, you don't have any responses on the triggered EMG. But when the nervous tissue is stimulated, you can see the responses here in the anal sphincter. And also, not only through the stimulator, you can do this is a mapping which the surgeon uses a stimulator to map out the nervous tissue. You can also use a continuous monitoring modality by using transcranial stimulation and recording the anal sphincter MEPs and also SSEPs, ascending pathways. You can monitor continuously in pediatric population. So There is one video where for tethered cord, IONM was used. Again, this is the stimulator where the phylum is stimulated. You can see there is no response. And now as the stimulation is on the nervous tissue, you can see the responses. So very simple technique and very easy to use, not affected by age or myelination. Lipomeningomyelosis are also very common procedures where IONM is used. Here, the aim of the surgeon is to dissect the whole fatty tissue around the nervous plaque cord and keep the nervous tissue safe. So he will use a stimulator to map out the nervous tissue in between the mass of fibrous fatty tissue. So mapping and then continuous monitoring also can be performed. One modality which has caught recent attention is bulbocavernous reflex. This is a continuous reflex where you can continuously stimulate in males the dorsal nerve of penis with cup electrodes. In females, you can stimulate around the clitoris and get responses from the anal sphincter. So this is a reflex, and this gives an information about continuous reflex arc mechanism to look for bladder and anal sphincter function. So it has to be, it is reported in literature that this has very high specificity and this can be continuously performed. So this is a very new modality and most commonly being performed nowadays in these kind of surgeries. Coming to spinal deformities, kyphoscolosis, no doubt that IONM is very, very valuable, even for screw, to detect the screw position. So if there is a medial cortical breach, or even with low currents, you get triggered EMG responses in the nerve root. So we can use screw testing, which is nerve root testing. Also, when the screws are placed and the rods are finally placed, and then there is traction given on the spinal cord to correct the angle. With every 5 to 10 degrees of correction, it is said that you have to perform MEPs and check for MEP responses. So triggered EMG for screw testing and SSCP and MEP for the cord monitoring when the rods are placed and traction is performed. So these kind of cases are common. Brainstem lesions also, pediatric IONM is very commonly used. This is a case where 7-year-old child came with fourth cranial nerve palsy. You can see that the tumor is on the brainstem, and we are worried about cranial nerves. We are worried about ascending and descending tracts, brainstem. So in this case, we performed third, fourth, sixth, fifth, seventh, and also lower cranial nerves monitoring with triggered EMG. And also we performed SSCP and MEP for the ascending corticospinal, ascending posterior column, that is the sensory tract, and the descending corticospinal tracts with SSCP and MEP. And also we used a continuous suction stimulator, which while the surgeon was dissecting out the tumor, he was continuously using this, and this stimulates at the tip. So you can record triggered EMG responses and detect any cranial nerves or any neural functional tissue around the resection. And also BERA for integrity of the brainstem monitoring. So this was also used. So in total, cranial nerve monitoring, tract monitoring, and also brainstem auditory work responses were used in this kind of case. So coming to anesthesia for IONM, anesthetics cause dose-dependent decrease in amplitude and increase in latency, like in adults, and it's very difficult to and it's challenging to perform anesthesia for IONM in pediatric population. The ideal way to do it is with TIVA and with opioids, and I prefer to use zero MAC without inhalational agents, though there is literature that low dose inhalational less than 0.3 or 0.5 MAC inhalation agents can be used while IONM is performed, but TIVA is the gold standard. So if at all inhalational has to be used, desflurane is better than sevoflurane, and sevo is better than isoflurane to preserve MEP and other IONM responses. Propofol is the most common drug used for TIVA, and FDA recommendations say that Propofol can be used for induction above 3 years of age and maintenance of anesthesia over 2 months of age. One thing is we should be careful in children with mitochondrial diseases because these patients can be prone to propofol infusion syndrome. But a common question that is asked is when propofol is used for TIVA, does it lead to any side effects? No, with normal maintenance of propofol TIVA, propofol infusion syndrome has not been reported because this propofol infusion syndrome is seen only when dose of more than 4 mg per kg per hour or more than 4 days is used, the propofol is used. So it is relatively safer for using propofol for TIVA. PRIS can be manifested as metabolic acidosis, hypertriglyceridemia, rhabdomyolysis, cardiac and renal failure. So to do propofol TIVA, TCI or target control infusion is the best way to do propofol TIVA. It gives us a steady state anesthesia and it helps us to maintain propofol infusion beautifully without disruption. The two pharmacokinetic TCI models available are PITFuser and Kataria. Kataria can be used from 3 years on and weight from 15 kgs on. The PITFuser can be used from 1 years also, so 1 to 16 years, and from 5 to 61 kgs. So PITFuser is a very popular pharmacokinetic model for propofol TIVA, which is used. But the problem is below 1 year and below 5 kgs, so there is no TCI model available. So we have to use manual calculation of infusion of propofol, and these two are useful dosing methods. The Stewart propofol infusion scheme and the McFarlane infusion scheme can be used in this pediatric population when you don't have TIVA, that is TCI TIVA, or when you have a child which is less than 1 year of age or less than 5 kg, you can use this manual calculation, and then also titrate it to depth of anesthesia monitoring. So the other drugs like ketamine and etomidate can be used only to potentiate baseline recordings, not when the signal is lost in between surgery. Remifentanil, unfortunately, the Minto model for remifentanil is also for the TCI is about 12 years and more than 30 kgs. So for pediatric population, there is no TCI available yet. But remifentanil is very useful whenever it is available. Dexmedetomidine works beautifully with pediatric population, especially when you need to maintain good hemodynamics. I generally use a bolus of 1 microgram per kg slowly over 15 to 20 minutes, and then go at an infusion dose of 0.5 mics per kg per hour infusion, and works beautifully, preserves the IONM signals, and also gives a good hemodynamic control. Neuromuscular blockers, we should know when to use and when not to use. So depending on the IONM modality used, we should avoid the neuromuscular blockers. Some institutes also have TOF monitoring and use neuromuscular blockers up to a TOF of 2, count of 2. But it creates a lot of confusion, so I would rather avoid this and directly go for without relaxation, only TIVA with propofol, opioid, and dexmedetomidine. So to summarize all the anesthetic agents and their effects on the IONM signals, this is the table. I'll be sharing this later with you. Regarding depth of anesthesia monitoring, it is recommended to use process EEG monitoring more than 1 year in more than 1 year kids. Less than 1 year, the problem is the process EEG is unreliable. This is because of the immature brain, and the EEG changes because of the lack of cerebral maturation. So there is a lot of need for developing pediatric processed EEG algorithms, also to have smaller sensors. The adult sensors are generally too big for small pediatric patients. So probably this is one area where we need to improve and get new research going. The other challenges are temperature. Hypothermia is a major concern. To maintain temperature in these kind of pediatric population is a major concern, and hypothermia is one of the most common factor where IONM signals are dampened. And the other thing is bite blocks for tongue injuries should also be placed meticulously, and there are various ways by which we use bite blocks. The silicone bite blocks work very well when they are placed between the jaw, and we also can rose gauze pieces, but in prone position and lateral position, it's very important to keep these bite blocks in place. Also, always the cold saline or irrigation fluid should be ready to give to the surgeon whenever there is an episode of seizure, and this effectively controls the seizure whenever we encounter them, especially in direct cortical stimulation. So whenever there is a drop in signal, always checklist has to be followed. We have to check the hemodynamics, check the metabolic parameters, temperature, blood loss, anemia, all the metabolic parameters, and then anesthetic factors that any boluses were given, and then look for technical factors if there was any technical glitch which led to loss of signal, and then finally the surgeon can be warned. So this is a checklist that every time an IONM signal has been lost or the amplitudes are reduced or the latency is increased, we go with this checklist. So this is one such case where interestingly we used anal sphincter MEP monitoring in a conus medullaris lesion. So you can see in between the surgery we lost one side, we lost all the lower limb MEPs, but the anal sphincter was still intact, and the opposite side everything was intact. So what we did was we chose to stimulate unilateral anal sphincter or unilateral MEP stimulation. So when we stimulated the opposite side, you can see that the lower limb leads are still lost. The IONM, the MEPs are still lost, but the anal sphincter is intact. The opposite side is the same side, the MEPs are not getting recorded as expected. But when we stimulated the opposite side, the MEPs from the lower limbs and the anal sphincter were intact. So in this way, we could differentiate that the anal sphincter was not because of direct, spread because of proximity. So it was actually a true drop in lower limb MEPs. And then we warned the surgeon, and he irrigated with warm saline, removed the retractor, and then you can see that the MEPs are slowly coming back, and this patient woke up without any neurodeficit. So in this case, we tried to do unilateral anal sphincter MEP monitoring, and we could map that if we even stimulate unilaterally, we can get anal sphincter MEP responses. So this was an interesting case which we published. So to conclude, IONM in pediatric neurosurgery is safe and it betters the outcome by preventing neurodeficits. Understanding of anatomy, physiology, and age-related changes is very important in this pediatric population who come for IONM. So this is the summary of all the procedures which are commonly performed in pediatric neurosurgery with IONM, and each modality, what are the anesthetic agents that we can use and avoid. It's all summarized in this table. So all these tables are present in this review of literature which we published last year. I can share it with you if you write to me. This is my email ID. Please feel free to write to me. I can share the reference and the article as well. So all the concerns about pediatric IONM have been addressed in this review article. Thank you so much. Thank you for the opportunity, and hope you all are safe.